ready? So, which patient presentation is least likely to be associated with minimal change disease? 65-year-old white male with AKI and 4+ proteinuria, 32-year-old white female with 2.1 grams of proteinuria per day, 45-year-old black male with 9 grams of proteinuria daily, 28-year-old white male with hypertension, microhematuria, and 4+ proteinuria. Okay, everybody vote. This is anonymous, but I am going to look at the front rows and see what you're voting for. Not really. Okay. Well, this is a mixed bag here. Okay. So, these are always reflections of how good my questions are or what you've heard today. So this represents minimal change disease, which, Anna told you before is probably a misnomer because it's not minimal change for the patients who have it. But one of the things in minimal change disease is significant proteinuria. When somebody presents, they don't present with a gram or 2 of proteinuria. They present with a lot of proteinuria. It may just be 4+ on the dipstick, 9 grams a day. It's unusual to present with 2.1 grams of proteinuria. So 33% of you got the answer that we were looking for. And let's see, here we go. So here's our minimal change disease. Remember the old name was nil disease, nothing in light microscopy. Our fused effaced foot processes here. Okay, so this is taken from a series that we did at Columbia of 95 adults with minimal change. It's one of the largest series of adults with minimal change. You can see we had a white predominance, and our population has about 20% black and significant Hispanic, but it was a white predominance here, average age 45, etc. The serum creatinine was 1.4. These people get some volume contraction with their markered hypoalbuminemia, so the creatinine is often a little elevated. If you looked here, proteinuria, the mean proteinuria was 10 grams a day. That was the mean. There was nobody down. I think the lowest was something like 3.8 grams a day, and that was an outlier already. So again, the person with 2 grams of proteinuria is unlikely to have this. Now, if you looked at the course, the remission rate was identical if we used daily or every other day steroids, but you can see this is 16 weeks, 4 months. The curve is flat after 4 months. A child is resistant in minimal change disease after 2 months of steroid resistance. In an adult, you have to go 4 months. Whether it's daily, every other day tapering, it takes a longer time to call an adult resistant. And if you're interested in the relapse rate, again, whether it's daily or every other day here, now you're looking here at, this is the relapse-free. So 60% were relapse-free a half a year after treatment. Of all the responders, which was almost everybody, 40% had relapsed in adults by the end of 6 months. If you go out to a year, there's a little higher relapse rate over time. Okay, question 2. A 38-year-old white female has the nephrotic syndrome due to biopsy-proven minimal change disease. She's responded to a course of prednisone with a complete remission, but has relapsed 3 times whenever she discontinues the prednisone. Which therapy will give her the highest remission rate for treatment at this time? If she takes which one of these different medications is she going to have the highest remission rate? Cyclosporin, cyclophosphamide, tacrolimus, mycophenolate, all of the above are equivalent. Dun, 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 dun. Okay. And the vote is, here we go. Well, all are equivalent. 33%, that's the best. We'll see if we should have 100% on one of these answers as we come along. So what's the data for this? So this is a graphic form. It is in that paper in C. Jason, but we never put it in graphic form. But if you look at either complete or partial remissions, this is after you've had prednisone, you've responded. This is your second or third, relapse, etc. You get treated. So you're steroid dependent or you're a frequent relapser. You are not steroid resistant now. Whether it's Cytoxan, cyclosporin, TAC, MMF, complete and partial are all about the same. There's no major difference. The major thing to do is if you have somebody who's a frequent relapser or somebody who's steroid dependent, think about what side effects do these drugs have. If the person has an elevated creatinine and hypertension is bad, you may not want to use cyclosporin or TAC. If they're female, you might not want to use cyclosporin. If you're worried about fertility, you might not want to use cyclophosphamide. Again, but the response rate is equivalent in steroid-dependent or frequent relapsers. Now, I didn't put this on here, but if you're steroid resistant, the response rate was about the same, except it's way down here. It's much lower for all of them. Okay, question 3. Which clinical and laboratory features suggest an obese nephrotic patient is more likely to have secondary than primary focal sclerosis? We know obesity is associated with secondary focal sclerosis, so which features suggest that an obese patient has secondary focal sclerosis rather than idiopathic disease? Is it black race and 9 grams of proteinuria a day? White race and 3.5 grams of proteinuria per day? BMI over 40 in the absence of hematuria? BMI over 40 and a plasma albumin less than 2? Okay. And the vote is, we're getting a pretty mixed audience here, aren't we? Okay. You know, the good thing is this is not the boards. Okay. So it turns out if you take people with secondary obesity-related focal sclerosis, the most common features are white versus black, because remember, in African Americans, idiopathic focal sclerosis is much more common. But in secondary, whites, blacks at least equal, and probably whites even more just because white race is more common in the United States. The other thing is the secondary forms have lower proteinuria, absence of edema. So if you have somebody who's white with 3.5 grams of proteinuria per day and they have no edema, you can guess statistically that that person is a secondary form due to obesity. And here we go. Here's our obese patient. And what do we expect? Here's a normal glomerulus. Look at the size of the tubules compared. Here's an obese glomerulus. Obesity-related glomerulomegaly. You can see the sclerotic lesion there. The other thing that's true, of course, is that you get some sclerotic lesions with these giant obese glomeruli. But if you look at the course of idiopathic focal sclerosis, it goes downhill much faster than either obesity-related glomerulomegaly with or without focal sclerosis. So given that, the white person with less proteinuria is more likely. Now, can you be sure? No. And what if you have a black patient who has 4 grams of proteinuria or 5 grams of proteinuria? Or what if you have a white person who has 6 grams of proteinuria? You can't be sure on any of these. The answer is do the biopsy if you're not sure. Okay, straightforward. Which genetic defect of focal sclerosis is not associated with an autosomal dominant inheritance? Not associated. That is, which one is not autosomal dominant? Alpha-actinin 4, inverted formin 2, Potosin, TRPC6. Okay, these are all common genetic defects that lead to focal sclerosis. Some of the most common that lead to it. It's not common to have them, but if you had kids, it would be common. But which one is not a dominant? You guys aren't pressing your buttons or... Oh, there we go. Okay. Okay. See, now we're predominantly in the right group here. Potosin. Potosin is a recessive. All the others are autosomal dominant. Now, it turns out that if you look at these in a large population, what you're going to find if you look at adults is very little. We actually did the study with Martin Pollack when he was at the Brigham, that we looked at something like 148 patients at Columbia that were adults with focal sclerosis. We found 2 compound heterozygotes for Potosin. That was it. There was nobody else who had a genetic defect. But if you take people with multiple family members or even one other family member with focal sclerosis, if you take kids, you're going to start finding these. And again, Alpha-actinin 4 would be one, TRPC6, of course, and now what may turn out to be the most common is the inverted formin 2. Which statement is not true about the incidence of focal sclerosis? The incidence of focal sclerosis is increasing in the U.S., and it is the most common pattern of idiopathic nephrotic syndrome in African Americans. The incidence of focal sclerosis is increasing in whites in the U.S. The incidence in most other Western countries is just as high as in the U.S. Focal sclerosis is the most frequent form of idiopathic nephrotic syndrome to lead to end-stage renal disease. One of those is not a true statement. Therefore, 3 are true. So which one is the not true statement? Okay, so we're getting better. 53% are correct. The incidence in most other Western countries is as high as that. That is not true. Let's look at the data. So this is taken from a study by Mark Haas from when he was at University of Chicago, looking at a 20-year time period here. And if you look at this 20-year time period, here's the incidence of minimal change. 4% of the biopsies, native biopsies, 3%. Here's membranous, 14%, 16%. Here's focal sclerosis, 3%, 18%. A huge increase. Same thing at Columbia over the same 20-year period. All focal sclerosis, a tremendous increase, got up to about 20-something percent, 21, 22%, and has leveled off. If you look at other countries, though, they don't have a 20% incidence of focal sclerosis. If you look here at nephrotic syndrome biopsies, here's the incidence: Spain, Italy, Denmark, Japan. Korea's, this is, data that has to be looked at differently because you can see 59% are minimal change. There are kids in here. That's what it is. But again, there's a significant percentage. It's nowhere near as high as the U.S. If you want to look at unbiased data, probably the best unbiased data, it's Dan Catran's data from the Toronto Registry. Because again, every patient in the city of Toronto, when they get a kidney biopsy, it gets logged in. So there's no sampling error here. So if we look at membranous as our stable control over 5-year periods, you can see it's about pretty constant. Now look at focal sclerosis. Same progressive increase over time. And that continues to go up, by the way. One thing that's interesting is the incidence of focal sclerosis is increasing in Caucasians as well. This is data that's taken from Olmsted County, Minnesota. Now, if you're not from the United States, Minnesota is a state in the middle of the country. Olmsted County is a county in the middle of Minnesota. There is one city in Olmsted County, Rochester, Minnesota. There is only one thing in that city, the Mayo Clinic. They get lots of biopsies, but if you just take the biopsies locally from the county, everybody is the same genetic Swedish farmer stock. The entire county, they're all farmers. Everybody is white. I put down over 90% white. My friend Fernando Fervenza says, oh no, Dr. Appel, 99% white. But whatever. Those are mostly Caucasians. Look at the incidence of focal sclerosis just from those biopsies. 5.7%, 18%, 20%, the same increase. One of my former fellows who's at Lenox Hill Hospital in New York, again, has a totally white population, same progressive increase. So focal sclerosis is increasing in whites and blacks. We're not sure why, but it's definitely idiopathic and secondary forms are going up over time, but it's more common in the United States than it is in other European countries, in Western countries, and it is the major cause of end-stage renal disease if you take idiopathic nephrotic syndrome. Okay, question 6. Which therapy has been studied in a control randomized fashion in adults with focal sclerosis? I'm guessing that 95+% of you are adult nephrologists here. So which has been studied in a control randomized fashion for focal sclerosis? IV pulse solumedrol, cyclosporin, rituximab, IV cyclophosphamide. I'm going to give you a number of these questions because I think it's very important that you know what's been done in a controlled fashion and what's been done anecdotally, even though we do it all the time. We don't have any good music that goes with this, while they're guessing? No. Okay. So, even though this looks like, a total splay, at least the majority or the biggest group is getting the answer correct. It is 33%. It's cyclosporin. If you look at this, there are no control trials of IV pulse solumedrol. Rituximab has certainly not been seen in a control randomized fashion that, there's only one disease that it's really been looked at in a control randomized fashion. And IV cyclophosphamide has not been studied. Cyclosporin has been studied in the North American Collaborative Study. And this is the study. Dan Catran was the lead investigator here that you'll meet Mark Pohl later on in the course. It looked at placebo versus cyclosporin for steroid-resistant focal sclerosis. You can see the average proteinuria was 7 to 8 grams. The creatinine was pretty well preserved, low albumins in this group. They got 26 weeks, a half a year of therapy. At the end of 26 weeks, 70% of the patients were in a partial or complete remission. But we stopped at that point because we were worried about cyclosporin toxicity. Remember, this is published back in 1999. It's way back. Nobody was sure that the drug was safe long-term in terms of a benign population. So there were relapses, but even if you go out to 104 weeks, many more patients were in remission if they got the cyclosporin. Now, what did that mean in terms of kidney function? If you look at the percentage of patients with a 50% decline in creatinine clearance, the placebo group had many more than the cyclosporin group, even as you go way out over time. You can see you're at 3 to 4 years here. So given that, the cyclosporin led to more remissions and it led to better function. Many people, let's see if I can go back, many people would not stop here. Now they'd give a year's worth of therapy and be up here with a partial and complete remissions. Many more complete remissions, they're up here. Then in the last 2 months, between 10 and 12 months, they taper the therapy. So if there's going to be relapses, they're up here, not way down here. But again, that was the original study. Now, there is the trial of cyclosporin versus mycophenolate. This is a trial that it was supposed to be pediatric, but it got up into the people in almost 40-something years old were included. We had 8 adult patients at Columbia in the trial. So if you look at this compared cyclosporin to mycophenolate for steroid-resistant focal sclerosis. Here, the darker bars are the cyclosporin. You had a little greater drop in proteinuria. This is a change in GFR, but the GFR came down more over the 26 weeks of therapy with cyclosporin than with mycophenolate. At the end of a year's worth of follow after the 6 months of treatment, 25% of both groups were in complete remission. It was the same number in both groups. From this, KDIGO has extrapolated that mycophenolate is as good as cyclosporin. It's not statistically significant. The numbers are much smaller than you would like to have. But if you want to point to data in a trial, you can say, yes, mycophenolate did just as well as cyclosporin in this underpowered study. Rituximab, if you take steroid-resistant patients as opposed to steroid-responsive focal sclerosis, this is one of many trials here. Magnasco's trial here. The R is the rituximab group, and we're looking at proteinuria here. There is no significant change versus the placebo group here. The dose of prednisone, the dose of calcineurin that needed to be used was identical. So for steroid-resistant focal sclerosis, the data on rituximab is not that good. It's much better for steroid-dependent or frequent relapsing disease. And finally, ACTH, not used in a randomized control fashion. This is a study that it's half Columbia and half Stanford. So we looked at 12 patients at each institution Our patients had failed at least 3 medications for their focal sclerosis, 3 immunosuppressive drugs. The results were about 30% had either a complete or very good partial remission. So the partial remissions, you can see, really got their protein down and their creatinine was improved. But in any case, it's 7 here out of the 24. That means 17 didn't respond. So is this good news or bad news? The good news is that people who failed multiple therapies can respond to ACTH. The bad news is that 17 of the 24 did not respond. So we need a control randomized trial. There may be a trial coming up on this. Right now, it's anecdotal data. But again, if you fail multiple therapies, I would not use it before that, but if you fail multiple therapies, I probably would lean to ACTH rather than rituximab at this point. Okay. Which is a common feature of idiopathic membranous nephropathy? Calcium oxalate stones, uric acid stones, renal vein thrombosis, struvite stones. I'm very interested. Okay. 98%, okay, that means 2% of people were asleep when David Salant mentioned that there's a thrombotic tendency, that renal vein thrombosis occurs, and you should et cetera. He went through this whole anticoagulation thing, or they may not have been here this morning. We don't know. Or they may have hit the wrong button. There are many different reasons for why this 2%, but why they're both here on uric acid stones, I don't know. In any case, forget about stones and membranous. Yes, there is a coagulation tendency. Everything tips over towards the clotting system. There's increased coagulation, whether it's platelet hyperagglutability, a high fibrinogen and fibrin transfer, decreased fibrinolysis. You lose anti-clotting proteins like antithrombin 3 is a small molecule. It's lost in the urine, so you have very low levels. Everything leads towards clotting. Deep vein thrombophlebitis, renal vein thrombosis, and pulmonary emboli are common. Clearly, if you take all nephrotic patients, membranous is number 1. In some series, up to 35% of patients have had evidence of a clot someplace with membranous. Now, most renal vein thrombosis is totally asymptomatic. You have to look for it or else you're not going to find it. But some patients get flank pain, microhematuria, and even a low GFR. So, renal vein thrombosis in membranous, these are both membranous patients. Here is somebody a longer time ago. Here's the inferior vena cava. Here's the renal vein. You can see the normal radicals, the lower pole of the renal vein here. Here's the upper pole. The kidney would look like this. You can see the filling defect, and the filling defect is going right towards the vena cava here. Renal vein thrombosis, membranous. Okay, we don't do vena cavograms anymore, but we do MRVs and we do CAT scan venography. Normal kidney, normal renal vein, swollen kidney here. Here's the renal vein, vena cava. Here's the clot right here, the filling defect, membranous nephropathy. And sometimes you don't even have to do that. This is a patient who was followed at Columbia with membranous nephropathy. She was admitted to 2 New York City hospitals with a diagnosis of pneumonia within 1 month. They never cultured an organism. She had low-grade temperature, shortness of breath, cough. She was having pulmonary emboli. When she came back to see us, she had dilated collaterals all the way from the hypogastric up to the axillary vein on the right. She had total right renal vein occlusion and partial inferior vena cava occlusion. Again, membranous nephropathy. And somebody like this with a low albumin, you have to consider anticoagulation as long as they're not high risk for bleeding. Question 8. Which features on the biopsy of a patient with membranous nephropathy suggest a secondary form of disease rather than idiopathic disease? Now, some of you are going to say, I don't want to answer this question. I'm going to send out for the phospholipase A2 receptor antibody. That's fine, but you know there are false negatives and false positives. Some of you will say, well, my institution already stains for it. I mean, Columbia does routinely stain for it, okay? But still, there are things that I still look at on the biopsy that are helpful. Is it segmental scarring, mesangial deposits, global glomerulosclerosis, subepithelial deposits without spike formation? One of those things suggests it's a secondary form, and you have to think of secondary forms of membranous, whether it's tumor, whether it's hepatitis B, whether it's medication-induced, lupus, etc. So what do we think? There we go, 49% here, mesangial deposits. So mesangial deposits in a membranous should always suggest the possibility. About 10% of idiopathic will have mesangial deposits, but it should always suggest looking strongly for secondary forms. And if you have a young female patient who presents with idiopathic nephrotic syndrome and the biopsy comes back membranous, the things to look are there mesangial deposits? Are there tubular reticular inclusions in the endothelial cells? Is it full house staining? IgG, IgM, IgA, the three immunoglobulins, C1q and C3, the two complement components. It's a full house hand in poker, three of one kind, two of another. If you have full house staining, you have mesangial deposits in TRIs, that's somebody who you have to look forward that she's going to develop lupus over time, or it's a membranous lupus-like picture. If it's a 60-year-old guy, very unlikely, but they're not going to have those other findings. Anyway, segmental sclerosis, global sclerosis, subepithelial deposits without spikes would be stage 1. All of those can be seen in idiopathic membranous. Again, phospholipase A2 staining now is very routine. But of the patients that David Salant showed you this morning, 3 of those who were thrombospondin 7A, 3 of those were Columbia patients. If you look back, he's thanking me, Pietro, and Andy Bombeck all individually because we each sent a patient in. I mean, the other, even though they're only 5%, 3 of them were Columbia patients. So you can indeed find other antigens that would stain negative for the phospholipase A2 receptor, even though it's, quote, idiopathic. Which test is usually not part of the evaluation of a patient whose kidney biopsy shows the following pattern? Now, this may be a little unfair because we don't know what Helmut has done with you yet in terms of he gets 3 lectures, okay? So you have somebody who has this pattern. Would you do this, 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 or this? Which would you not do, okay? There we go. Well, we're getting better. We're maturing. Or getting used to my questions. 74% are correct. This is very unlikely to be anti-GBM disease. Anti-GBM disease is a crescenteric disease. There should be proliferation in Bowman space, but there's no extracapillary crescenteric proliferation here. But this is a typical membranoproliferative pattern. The membranoproliferative pattern, one of the old names was lobular. You can see how it's broken into lobules here. You can almost see clefts between them. You can see reduplication of the basement membrane here, the black tram tracking, a double membrane in terms of many places along the line here, and no extracapillary proliferation. Here again, you can see that beautiful tram tracking, that double thing. The MPGN pattern is quite typical of most hepatitis C virus related and some hepatitis B. Certainly if you take people who have light chain deposition disease, heavy chain deposition disease, they'll get a pattern like this. Lupus, absolutely. There's an MPGN pattern. It falls under the diffuse proliferative category of lupus. Good pastures anti-GBM should have crescents. Which therapy has not proven effective in producing remissions of the nephrotic syndrome in a randomized control trial in idiopathic membranous? So one of these has not been studied in a randomized control fashion. Is it tacrolimus? Is it alternating months of steroids and cyclophosphamide? Is it ACTH? Is it rituximab? We're talking about idiopathic membranous. Which one has not been studied formally in a randomized control trial? I hate to harp on randomized control trials, but that's what they're interested in. That's where the data comes from. Okay. Okay. So now we've got you. Only 24% are right on this one. Rituximab has not been studied. ACTH has been studied in a randomized controlled trial by Ponticelli, and I'm going to show it to you. So, of course, if you look at the Italian regimen, Ponticelli's regimen, alternating months of steroid cyclophosphamide, steroid cyclophosphamide, steroid cyclophosphamide. And again, he started using chlorambucil but switched to cyclophosphamide along the way because it gave less side effects and was equally effective. But if you look at that, if you look over time here, here's the control group, here's the proteinuria dropping in the treatment group, here's 1 over the plasma creatinine stable in the treatment group. KDIGO actually says this is first line. If you're using a calcineurin inhibitor as first line for membranous, again, as David said this morning, you're not wrong because most American nephrologists would do that. In Europe, they'd use the Ponticelli regimen first. Here's the North American collaborative trial. I showed it to you for focal sclerosis. Here it is for membranous. Here is the treated group with cyclosporin. Here's spontaneous remissions. You're treated in here. Even if you go out to 78 weeks, you still have more partial and complete remissions. Here's Praga's study with tacrolimus. Again, if you look here at the control group, this is the percentage of patients with a 50% increase in serum creatinine. So the control group is progressing while the treated group does not. They have many more remissions. So calcineurin inhibitors have been studied, both TAC and cyclosporin, that clearly Ponticelli's regimen has been studied. Here's Ramuzzi's data on 100 patients with idiopathic membranous treated with rituximab. If you look over time, 3 years, 4 years, 5 years, complete and partial remissions. Now, this is not really, it looks like it's close to 100%, but it's not really that high. It's in the 80% range here. But it's up here, complete and partial remissions here. That is not a control randomized trial. That is 100 anecdotal patients that are all put together. And I always like to say that this article, which a lot of people refer to, that as a study which shows that rituximab works, well, it does, but it does not, as Beppe Ramuzzi said, make it a first-line drug. He suggested it's a first-line drug. I'm going to tell you why it's not a first-line drug. There was a very good editorial that went back-to-back with this article explaining why it's not first-line for membranous. And since I wrote the editorial, I'm going to show it to you. So here it is. KDIGO recommends alternating months of steroids and alkylating agent or a calcineurin inhibitor. Why do they recommend it? Those are all tried in control randomized trials. The rituximab has not. The current study was not randomized, no controls. 2/3 of the patients never had any other therapy for membranous. They went right on rituximab from day one. Well, again, why would you take an expensive drug that hasn't been shown in a randomized fashion and use it as a first line? You want to use things that have been already tried and that they're very inexpensive. The safety data, I admit, rituximab is a pretty safe drug, that there's lots of, 250,000 people with rheumatoid arthritis have been treated with rituximab, so it's not like a new drug. But the cost, there's no doubt it's going to be more expensive than cyclosporin or tacrolimus. And as Ramuzzi said, we need a control trial. Well, there is a control trial. The Mentor trial is rituximab versus cyclosporin. Of the 156 openings in that study, last week there were only 6 left. I'm trying to get one patient in. I think the 6 slots will be taken by the end of next week. That's how fast it's recruiting. It's got 2 great arms for the study. It's 6 months of therapy. If you're responding, you get 6 more months of therapy. At the end of that, you get followed for a year to look at the relapses. That is a control randomized trial. If rituximab matches or is superior to cyclosporin, then I will say yes, I'll take that question out for next year. But at the current time, no randomized control trial with rituximab. Oh, and for ACTH, here's Ponticelli's study. I would just point out that group A and B are totally matched in everything. Just as you might expect, Claudio did a very good job. If you take the group that got alternating months of steroids and cyclophosphamide for membranous, they start with 4 to 10 grams of proteinuria. These are complete remissions. These are partial. These are no remissions. If you take the group that gets ACTH, they start with 4 to 13 grams of proteinuria. Here are complete remissions. Here are partial. Here are no responders. Now, that's not Acthar. That's synthetic ACTH, which they had in Europe. They don't have Acthar in Europe. We don't have synthetic ACTH available here. But regardless, it is ACTH. It is a control randomized trial. So not robust in terms of numbers, but it's a control trial. Okay, question 11. Which statement is true about the use of rituximab in control randomized trials of glomerular disease? Rituximab has proved effective in diffuse proliferative lupus. Rituximab has proved effective in ANCA-positive vasculitis. Rituximab has proved effective in membranous lupus nephropathy. Rituximab has proved effective in steroid-resistant focal sclerosis. We're going to see if somebody had yes. Actually, this is the one that I thought would be 100%, but it shows some of you had too much to eat for lunch and you're drowsing off here. So it is clear, ANCA-positive disease, the RAVE trial, the rituximab trial, control randomized trials which show that rituximab does work. That it does not work in diffuse proliferative in randomized control trials. I showed you the LUNAR trial this morning. It was not effective. Maybe it was underpowered, but it did not give you statistically more improvement than over placebo. In membranous, we just said that, see, even though I just said that 2 minutes ago, but 8% of you don't believe me that I just said the study isn't done yet. We have to wait for the Mentor trial. And I showed you this slide about 5 minutes ago. So here it is. It's ANCA-positive disease. Here's the RAVE trial, 197 patients. Half get rituximab, half of them get oral cyclophosphamide, and after the oral cyclophosphamide for 3 to 6 months, they get put on azathioprine. I want to point out that this group just got 4 doses of rituximab. They both get steroids, but this group gets no azathioprine, no continued doses of rituximab. Let's just get to the, here it is. At 6 months, complete remission, no activity in any organ system, and no steroids. You have to be off steroids and have complete remission. 64% of the rituximab, 53% of the cyclophosphamide here. And again, the cyclophosphamide was followed by azathioprine. Here's the secondary endpoint, any dose of steroids. It was a tertiary, but the secondary was less than 10 milligrams of prednisone, complete remission, no activity. Again, the rituximab looks better. It's not statistically significant, but it certainly was no worse than cyclophosphamide. The same thing was true at 18 months, even though one group kept getting azathioprine and the other group just got those 4 doses of rituximab. So the RAVE trial certainly shows that rituximab is a player there. We'll talk a little bit more about this in a minute. A 23-year-old white male presents with an episode of dark urine following an upper respiratory infection. He's found to have a blood pressure of 142/92, but the rest of his physical is normal. He has a BUN of 22, creatinine of 0.9, 24-hour urine protein of 1.8 grams per day. He has many RBCs and dysmorphic RBCs on his urinalysis. His biopsy shows 25 glomeruli, 40% have mesangial proliferation, 2 have segmental crescents. His IgA in the biopsy is 3+ positive, the IgG is 2+ positive, lambda and kappa are both positive. There are mesangial electron-dense deposits. What features portend a poor prognosis in this patient? Age 23 and gross hematuria, blood pressure 142/92 and 1.8 grams of proteinuria, active urinary sediment and blood pressure 142/92, mesangial proliferation in 40% of the glomeruli, and 2 segmental crescents. There we go. Okay, so the answer, unfortunately, the majority didn't win here. It's 45%. Okay. The blood pressure elevation, which is shown here, is a prognostic factor and a bad one. The other is proteinuria. The more proteinuria you have, the worse you're going to do. Now, the age and gross hematuria don't mean anything. Active urinary sediment is very common in these patients, so that would not be prognostic. Mesangial proliferation, I put this on for a specific reason. Mesangial proliferation, in order in the MEST score to get the 1 point as opposed to getting 0, you have to have over 50% of the glomeruli with mesangial proliferation. This guy only has 40%. He doesn't even get an M1, he gets an M0. Two segmental crescents is very common. This is not crescenteric IgA. Remember, we said you might need 50% crescents, 40%, 35%, but nobody who has 2 out of 25 glomeruli, less than 10%, is going to be considered a crescenteric. It's very common to get a couple of small segmental crescents in IgA nephropathy. So the answer here is the hypertension and the proteinuria. Okay. A 22-year-old white male is seen with a creatinine of 1.8 and 2.4 grams of proteinuria per day. On physical examination, he has the following skin changes. Okay. Which would not be a typical finding in this patient? The guy has those skin changes. Which would you not expect to find in this patient? I could see this on the boards. This is the kind of thing they do. They show you one thing and then they ask, what goes with it, what doesn't go with it. Okay, and the vote is for, good, 48% are correct, and that's actually good. I like this. So this is Fabry's disease. Those are typical, angiokeratomas, which are found in the bathing suit area. After lunch, I couldn't, I either have to show you the front or the back, so either way, it's not going to look so good. But in any case, you can get eye changes and corneal changes. You can get acroparesthesias. Sometimes you get discoloration, but again, acroparesthesias are common. Lack of sweating, anhidrosis, is again another thing. In the glomeruli, you usually get in the podocytes the zebra bodies. And here you can see them all here. Here's the capillary loop. Here's another. This is taken from somebody with Alport's. Here you can see the lamination of the basement membrane. So you look at this, it's Alport's. You look at that, it's Fabry's. So again, the majority are correct here. A 22-year-old white female with a 2-year history of proteinuria and hematuria has this biopsy. Which is not likely to be found with this lesion? A positive ANA, C3 nephritic factor, low factor H level, low C3 level. Okay, 44% are correct. I'm still asking tough questions, I can see. So I did make it, if I had made it a 42-year-old male, I think a lot of you wouldn't have guessed the ANA. But if you look at this is clearly a lobular picture. You can see the double contours, so it's an MPGN, tram tracking, again, double contours and lobular. So it's an MPGN picture, and we look on electron microscopy, there is this dense deposit going all the way through the basement membrane. This is dense deposit disease, the old type 2 MPGN, but now everybody calls it dense deposit disease. It's a disease of the alternate pathway. You may have C3 nephritic factor, you may have a low factor H level in terms of this by a hereditary deficiency or an antibody, and a low C3 level would be expected. This would be very unusual for a patient with lupus. The deposits should be subendothelial deposits, not this ribbon-like everywhere. Every single basement membrane is here. So you wouldn't typically find the ANA here. It's not a lupus patient. This is a dense deposit disease patient. Again, dense deposit disease, we have a lobular picture. We have C3, but no immunoglobulins. Not like in lupus where we'd have IgG, IgA, full house staining here. And again, here you can see the density here. The other half of the alternate complement defect glomerulopathies, the so-called C3 nephropathies, is dense deposit and C3 glomerulonephritis. C3 glomerulonephritis often has just a mesangial proliferative picture, but again, you only get C3 deposited, no immunoglobulin. Here, you don't have the dense deposits, you just have some mesangial deposits here. So it's important nowadays to recognize that immune complexes work through the classical pathway. The alternate pathway is always on here. If you don't have the normal braking features that slow this down, you get C5a, which recruits cells, and the membrane attack complex, which pokes holes in cells. Again, this is triggered by antigen-antibody reaction. This alternate pathway is always on at a low rate. So in the old days, 5 years ago, we talked about MPGN 1, 2, and 3. Now we talk of dense deposit disease. Dense deposit disease and C3 glomerulopathy are both defined by only having C3 by immunofluorescence. It's not the EM that defines these. It's the immunofluorescence because that's the mechanism of the alternate pathway. If you have immunoglobulins here, then you might have the other MPGN type 1 and type 3, the older forms. Okay, question 15. A 32-year-old white male ex-IV drug abuser presents with edema. He has a normal blood pressure, physical examination is negative except for a 2/6 systolic ejection murmur at the apex and a non-blanching purpuric rash on his legs. He has a creatinine of 1.8 milligram per deciliter. His urine has dysmorphic red cells, and he has 3.6 grams of proteinuria. He has a negative ANA, ANCA, ASLO, SPEP. Serum complement is markedly reduced with a normal C3 and a low C4. Ultrasound shows normal-sized kidneys with increased echogenicity. So here is what we've got. Here are his legs. What is the most likely diagnosis? HIV-associated nephropathy, MPGN due to hepatitis C virus, proliferative GN due to SBE, AA amyloid. Let me just go back for 1 second for you. 32-year-old white male ex-IV drug abuser here, creatinine 1.8, 3.6 grams of proteinuria, negative ANA, ANCA, ASLO, SPEP, complement markedly reduced, normal C3, very low C4. Okay. Proceed to vote. Okay, well, the majority's wrong. You're not far wrong, though. I mean, you could be, well, no, you'd have to stretch it. The 48% are correct. So why is this not HIV-associated nephropathy? Statistically, it's very unusual in a white person to get HIV-associated nephropathy. The vast majority are African American. And again, this is related to the apolipoprotein 1 gene. You'll have more of that, during the course and everything, but still, that's very unusual. Okay. Proliferative GN due to SBE, that's always a possibility in a drug abuser, especially with a murmur, but here the C3 is normal. Usually in post-infectious, whether it's post-rep, whether it's SBE, whether it's any deep-seated infection, it is usually a low C3, more commonly than a low C4. If you take a low fourth component of complement, that is typical for MPGN associated with cryoglobulinemia and hepatitis C. And those are the legs that are typical for cryoglobulinemia. AA amyloid, I threw that in there. I don't know if anybody guessed that, but I threw that in there for people who've abused drugs and are skin poppers with chronic inflammation of their skin and everything. They often get secondary amyloid, AA amyloid. But again, this person does not have that. So here the most common thing would be hepatitis C virus, MPGN. Again, when you think of low complement, normally I tell people that the disease, I tell house officers, the diseases with low complement are lupus, post-infectious GN, cryoglobulinemia, which can be hepatitis C, and the diseases of the alternate complement pathway, the old dense deposit and C3 glomerulopathy that we just talked about. Those four things typically give you a low complement. So again, you're talking about lupus, post-infectious of any sort, hepatitis C and cryos, and whatever the fourth one I said was. Let's see, which did I leave out? What was that? Alternate complement pathway, of course. So those are the four. Now, if you then look at this and say, well, wait a minute, are there other diseases? Yes, there are. There are a few that you need to know about. Heavy chain deposition disease. Heavy chain deposition disease, if it's an IgG1 and especially IgG3 bind complement. Rare, but you're a nephrologist. You can have people with cholesterol emboli can have low complement. People with complement deficiency, certain lupus patients are complement deficient. So again, there are other things, but the important thing for you is C3 and C4. C3 is almost always low with post-infectious. C4 is much more likely to be low with cryos and hepatitis C. And for lupus, both of them go down hand in hand. Okay, question 16. A 27-year-old stock analyst has had 3 spontaneous abortions and Raynaud's phenomena. 2 years ago, she developed a deep vein thrombophlebitis of the calf after a long auto trip. She has arthralgias, low-grade temps, and malaise. Her blood pressure is elevated at 152/92. She has a malar flush, a systolic ejection murmur, swollen MCP and PIP, finger and hand joints. She has lividoreticularis of the legs and 2+ ankle edema. Her white count is low at 3,600. She's anemic at a hematocrit of 24%, and her platelets are low at 89,000. She has 3+ proteinuria, 3+ hematuria, 8 to 15 red cells. She has red cell casts in her urine sediment. BUN is 43. The creatinine is 2.6 milligrams per deciliter. She has 1.2 grams of proteinuria. Her PT is 14.6. Her PTT is 85. Her ANA is positive at 1 to 160. Her anti-double-stranded DNA is negative. C3 and C4 are only borderline low. The renal biopsy is most likely to show which of the following: diffuse proliferative GN, focal proliferative GN, thrombotic microangiopathy, membranous lupus nephropathy. Okay, that's good. 71% are correct. This is a typical person with antiphospholipid syndrome. If you look at this, this is a person with a high APTT. This is a person with lividoreticularis. This is a person with 3 spontaneous abortions in the past. This is somebody who's had a DVT before. They're lupus-like. They may have some manifestations, but their anti-DNA and complements are not active despite the fact that they have renal disease. So again, antiphospholipid antibodies are a family of autoantibodies. They can be IgG, IgM, IgA against negatively charged phospholipids. The lupus anticoagulant prolongs the coagulation tests, but it's not an anticoagulant. It is prothrombotic. Anticardiolipins bind to cardiolipin. They give you the old false positive VDRL here that they are all procoagulant. They all lead to thromboses. This is taken from a series from the Europhospholipid study. I think it was something like 1,200 patients, but DVT is number 1, thrombocytopenia, 22%, lividoreticularis, 20%. Now, renal manifestations were only 2% of all these patients in this series. Again, this is, a phospholipid thrombotic group that they're looking at. But still, if you look at it from a renal viewpoint, most of our patients are going to have renal involvement. But these are the things that we would expect to have. And you'll see fetal loss here, pulmonary embolus, thrombophlebitis, etc. Here's livedo reticularis. You can see this dilated network of veins on the surface of the skin. I have no idea why people, I've asked dermatologists innumerable times why people get livedo reticularis, and I get different answers, and none of them make a lot of sense. But if you see this in a person and you're at all suspecting a glomerular disease, the first thing you should think about is, could they be an antiphospholipid patient? Question 17. A 75-year-old white male presents with a 3-week history of low-grade fever, malaise, and a petechial skin rash. Biopsy of the rash shows leukocytoclastic vasculitis. Okay, it's an inflammation of the small blood vessels with breakdown products of the white cells. His creatinine is 4.8. He has 2.4 grams of proteinuria daily with red cells and red cell casts. His ANCA, his MPO ANCA, is strongly positive. Biopsy shows a crescenteric GN with no immunofluorescence staining for immunoglobulins or complement. It is Pauci immune. Which statement is true about the treatment of this patient's disease? PO cyclophosphamide is superior to IV cyclophosphamide in inducing remissions. IV rituximab and PO cyclophosphamide are equally effective in inducing remissions. IV rituximab is superior to IV cyclophosphamide in inducing remissions. If effectively treated, this person will have a low morbidity and mortality from therapy. Okay. So 43% of you are correct. Okay. Now, a big chunk said if effectively treated, he will have low morbidity and mortality, and I want to give you data on this. This is the rituximab study, the other study. Some of you were thinking, well, wait a minute, the RAVE trial excluded people, those 200 patients in the RAVE trial, it excluded people with a creatinine over 4. It did not, David may have misspoke this morning when he said pulmonary hemorrhage was an exclusion. 25% of each group had pulmonary hemorrhage. I may have misheard him, but 25% of each group in the RAVE trial did have pulmonary hemorrhage. You couldn't be on a ventilator. You couldn't have mechanical ventilation to get into the study. The two big exclusions were creatinine of 4 or above and mechanical ventilation. So you may say, wait a minute, this guy's creatinine is 4.4. But remember, the rituximab study was back-to-back with it. The rituximab study looked at rituximab here with steroid taper versus cyclophosphamide and methylprednisolone, followed by azathioprine. And the results were identical. If you look at sustained remission, the same. If you look at incomplete response, the same. The interesting thing is that in the rituximab trial, which wasn't the best designed trial for UVAS, UVAS has done much better studies, but in any case, if you look at the data in that study, that the mortality was very high. Why was it very high? The older the patient, the higher the creatinine to start, the higher the mortality. David Jane put this together for all the UVAS studies. If you look at increasing age and decreasing GFR, look at the mortality. Up, up, up. The rituximab here at 18%, MEPEX had 25% because they were old and they had even a lower GFR. So this guy, even if you treat him appropriately, is in a high-risk group because he's older with bad renal function. He's someplace up in here. On the other hand, the rituximab is probably equivalent to cyclophosphamide. Okay, question 8. I'm going to go through the next three quickly. Question 18, a 4-year-old goes to a petting zoo with her parents. She cuddles the sheep, calves, and other baby animals. She doesn't wash her hands. 3 days later, she develops abdominal cramps, diarrhea, bloody stools, nausea, vomiting, fever. She's given antibiotics by her pediatrician. Day 6, there were ecchymoses of the extremities and lips, thrombocytopenia, oliguria, and seizures. Her stool is positive for E. coli 0157H7. Which therapy has proven effective for this disease? Quinolones, plasma exchange, Synsorb, eculizumab, none of the above. Okay. None of the above is correct. None of these have been effective if you look at hemolytic uremic syndrome, even though there was a suggestion that eculizumab might be in the European outbreak, not really so. Now, I'm going to move ahead in terms of, because of timing. By the way, the petting zoo stuff, you have to go back. If you have children or grandchildren, now everybody brings along those little wipes because the petting zoos are just filled with bad E. coli, again, that can give you hemolytic uremic. In that episode in Florida, the big episode that with the 15 cases, 3 of the kids died. So this is a big league disease. Anyway, we're going to go beyond this. We don't want to. Okay, here we go.
You're okay, actually, because we're going to cut this last short.
Okay, we have 2 more questions here. A 36-year-old, previously healthy African-American female develops fever and bruising. She goes to her doctor. Her CBC shows that her platelet count is 15,000. Her hematocrit is 28%. She has a normal PT and PTT. On smear, she has a microangiopathic hemolytic anemia. Over the next few days, her urine output declines. She develops sudden blindness followed by decreased mental status. What should you do for this patient? Send for an immediate assay for the metalloproteinase ADAMTS13. Institute immediate plasma exchange and corticosteroid therapy. Institute immediate heparin and start Coumadin anticoagulation. Start rituximab and steroids. Good. So the good thing is that only 4% of people are sending out for an assay and saying, look, let's wait for a month until the assay comes back. The vast majority of you would do the right thing, which in this case is steroid therapy right away and plasma exchange. You will, again, this is classic picture for TTP with brain disease, renal disease, anemia, microangiopathic hemolytic anemia, low platelet count, that if you give them plasma exchange, you will, replace the factors. At the same time, you remove any antibodies to the ADAMTS13. So again, you're treating both parts of the disease at the same time with plasma exchange and with steroid therapy. If they don't respond or they relapse, that's when you consider the rituximab. So that wouldn't have been a crazy thought in terms of the people along the line. And let's see. Nope. Here we go. Last question. A 62-year-old white male plumber with mild hypertension is evaluated for proteinuria and edema. His blood pressure, borderline. He has an S4 gallop on his heart, no liver, kidney, spleen, 2 to 3 plus edema. BUN is 12, creatinine is 0.7. Urinalysis has 4 plus proteinuria, 2 plus hematuria. The 24-hour protein is 4.2 grams per day. ANA complement, hepatitis B, C, etc. are negative. He has 1.8 grams of IgG kappa and in his serum, and his albumin is 2.2. His biopsy might show all of the following except which? Which one is least likely to be found? 1, 2, 3, or 4? This is my most colorful slide. That's my last one. And it introduces Lori. Oh, I thought we'd get a winner here. Okay, 31% are correct here. So if you look at this person, what could he have? This person has predominantly albuminuria. The dipstick is strongly, let's go back one actually. Can we do that? Here. The dipstick is 4 plus positive for protein. Well, the dipstick is only sensitive to albumin. It doesn't pick up light chains and other globulins. He has significant albuminuria, normal renal function here, okay? Now he's got a kappa spike. So it turns out that, in most studies, about 80% of amyloid is lambda, 20% is kappa. So he could be, amyloid is very common. So he could have AL amyloid, and that could be it. And this is AL amyloid. You can see the entire glomerulus filled by this glassy eosinophilic material. Here's the afferent arteriole. Here, the tubules. Everything is surrounded by it. He could have light chain deposition disease. He has a kappa spike there. Here is light chain. If this thing, you say, well, what is it stained for here? Well, this is stained here for kappa. And here, you can look right along here, Bowman's capsule, every tubule, every TBM, every GBM stained. So that's what the old name used to be kappa chain disease, but it's light chain deposition disease due to his kappa. He could have what I think is becoming more and more common, a proliferative glomerulonephritis with subendothelial deposits associated with a monoclonal antibody. And again, in our hands, this is actually becoming more common than light chain deposition or heavy chain deposition disease. What he's least likely to have is every one of his tubules filled with casts. These are classic myeloma or light chain casts. You can see they fracture. There are multinucleated giant cells. You can almost make out laminations too, but it doesn't matter. Every tubule here is filled by a cast. The guy's creatinine is 0.7. He's not going to have a creatinine of 0.7 if he has bad cast nephropathy at the same time. So he's least likely to have this. He has a glomerular disease. It's one of these. But that's my take on it. Now you're going to get Dr. Denber's take on it. So I'll stop here. Thank you.